So it's a pleasure to be with you here this morning. We are going to be going through a few topics pertaining to interdisciplinary innovation in global surgery. So this is our outline. We'll just quickly situate ourselves in terms of what global surgery is, because again, it's a newer field. So we'll go through some definitions. We'll talk about the Lancet Commission on Global Surgery and its main indicators and findings. And then we'll spend the bulk of our time looking at drones and Stitch and how they fill an infrastructure gap in surgical care systems. And we'll end off with a brief touch point on the graduate diploma in global surgery here at McMaster. So the objectives, I think, naturally flow from that. So understanding the field of global surgery, articulate the main findings of LCOGS, the Lancet Commission on Global Surgery, develop an understanding of the infrastructure gaps that innovation can fill in this field using both drones and simulators as examples. Increase familiarity with embarking on interdisciplinary innovation. I think we do have a slightly skewed but still interdisciplinary crowd in our room here in person. And then finally, hopefully by the end of this, I'll be able to inspire you to pursue innovative interdisciplinary collaborations to address healthcare systems needs, no matter where you are in the world and what system you're working in. So my disclosure is that I am the co-founder of Stitch. Those of you that are here in the room with me will see it here on the table, and you're welcome to come and squeeze the uterus and whatnot afterwards and stitch it. But I and the rest of the team who you'll meet shortly do not derive any financial benefit nor revenue from Stitch at this time. All right, so we're going to start with global surgery. Just for those that are not as familiar with the term in the room and online. So I think most of us know about the term tropical medicine. This started back in the 1800s and it stemmed from colonial medicine. And so really the objective at that point was to ensure that the colonizers would survive and not succumb to things like dengue, malaria, yellow fever, and so forth. So there was really no emphasis at that point on health for all, health equity. Shifting to the 1950s, we saw huge political shifts globally. And so that's when countries were very concerned with containing pandemics and ensuring that they weren't crossing international borders. So then we saw things like eradicating polio, malaria campaigns, and so forth. And that brought us to the early 2000s when the term global health really came into play. And that's what we all know as this area of study, research, and practice that really is prioritizing health equity for all. And so this is looking at both health within a given country and the disparities there, but also the disparities between countries around the world. And of course, as we've all learned at various parts in our training, this comprises the various determinants of health. So the social, economic, political, and so forth. Now, global surgery was really put on the map in 2015 with a landmark paper published by the Lancet Commission on Global Surgery, which we'll touch on in one second. But essentially, global surgery is defined as the study and practice of improving access to timely, quality, and affordable surgical care for all. So it does, of course, include all of the traditional healthcare disciplines, our allied health colleagues, but also a number of other specialties like intensive care, peri-op, emerge, primary care, rehab, midwifery, nursing, allied health, and so forth. And so global surgery is all nested under global health. However, it's commonly misconceived that global surgery is referring only to the surgery or only the surgeon or only the anesthesiologist or only what happens in the operating room. But in fact, we're really talking about surgical care systems. And those of you that have heard me speak before will know that I like to describe it this way. So we're looking at the components of surgical care systems, how they interact, and then the barriers that interfere with those interactions. So some big components are, of course, the patient, the place, so where they're going, how they're getting there. So depending on where you live in the world, are you hiking 10 hours up a mountain at fully dilated to deliver your baby, which is what happened in Rwanda when I was there in 2008? Are you on a bike, ox-drawn cart? Are there roads? Are they dirt roads that are washed out by rainy season? Are they paved roads? But then there's a high rate of road traffic accidents, and maybe it's actually safer to not be on those roads. And let's say you get to the facility. Well, who are actually there? Who are the personnel that are staffing the facility? Are they there 24/7? What is their training? Can they safely perform whatever surgery is needed? Is there an anesthetist or anesthesiologist to give you safe anesthesia? And then what's the infrastructure at that facility? Is there safe running water, electricity? Do we have our usual healthcare commodities? So IV medications, blood, antibiotics, and so forth. And so very quickly, this is obviously a picture of an ultrasound. This was in Angola at a completely nurse-run hospital, and you're going to see a photo of this shortly. But they didn't know how to use this ultrasound. And so when myself and an American OB/GYN colleague arrived, we discovered that this patient who was sitting on the antenatal ward with bleeding in the second trimester was actually sitting there with a big gynecologic malignancy, diagnosed primarily via ultrasound at that point. And this is the blood bank at that same hospital. So we can then start to see that the discipline or the area of global surgery is really cross-cutting and relies on a number of professions and disciplines to make these surgical care systems safe and effective. So yes, the traditional and allied healthcare professions, but also our engineering colleagues and the innovators. So they're going to be responsible for things like, safe water supply, water boreholes, electricity grids, innovations that we'll talk about shortly. Information technology colleagues, they're going to help us do electronic referral systems, create our registries to collect data on various conditions or interventions. Journalism media folks will help us to amplify our messages, increase awareness, but also combat disinformation. Our law, policy, advocacy, and business colleagues will help us to finance various healthcare systems or efforts. Health admin, of course, is very important to help us run the entire system. And then our community health workers, who are lay people with no formal healthcare training, but have reach into communities and have community buy-in, are, of course, also critical. So again, I just wanted to start our time together with this, just to emphasize that when we talk about global surgery, it is not just limited to our traditional and allied healthcare professions, but really we require interdisciplinary collaboration. And a quick point here on the Lancet Commission on Global Surgery. So as I had alluded to, this was the landmark paper that was published in 2015 that really put global surgery on the map. And there were some main findings that show us the burden of global surgical needs. So it showed that 5 billion people lack access to safe and affordable surgical and anesthetic care worldwide, mostly centered around the dark red and bright red portions of this map here. Just for the people in the room, I'm going to try to move this so you can see the screen. 1.27 million additional surgeons, anesthetists, and obstetricians are needed by 2030 to meet global needs for surgical care. A third of the world's burden of disease is due to surgical conditions. And all of this is going to cost the world's economy $12.3 trillion between 2015 and 2030. Now, to put the burden of disease another way for you, we know from data that the total number of surgically avertable and treatable deaths every single year actually outweighs by more than fivefold the number of deaths from HIV, AIDS, malaria, and TB combined. And so, again, in terms of setting, when we talk about global surgery, many people think about low and middle income countries, both urban and rural remote settings. And this is just to illustrate to you a district hospital. So this is a district hospital that I worked at in Angola. Obviously, this is an aerial view. This is actually where that ultrasound and blood bank image were taken from. So this is 250 beds, completely nurse run and accessible only by Cessna plane. So yes, there are roads obviously in the image, but there are no roads connecting this hospital in and out to a larger center. And so if you need, specialists and so forth, they're all flying in by Cessna plane. So this is a classic district level hospital. But of course, people sometimes forget that global surgery also refers to high-income countries. And specifically, we're talking about our rural remote communities in high-income countries. Now, where we're sitting this morning, those of us in the room, us Southern Ontarians like to think that this is Ontario. And although, yes, 12 million people live in this red part of Ontario, this, of course, is Ontario. So our province is much larger. And that purple dot you see at the northwestern part of Ontario is Pakanjikam. So I actually don't know if she's online, but that is where Dr. Linda Redwood Campbell, one of our faculty for the Graduate Diploma in Global Surgery, works part-time. So Pakanjikam has this nursing station. And so Pakanjikam is an Ojibwe First Nation with a population of 2,400. For surgical care, my understanding is that one must find air transportation out to the closest center, which would be Sioux Lookout, about 420 kilometers away. So that's a 50-minute flight and $900. Now, if you need a tertiary care center and you live in Pakanjikam, then you're headed to Thunder Bay, which is 500 kilometers away, 3.5-hour flight, $1,400. And then let's say you need quaternary level care. You need to come to Hamilton. So that is a 13.5-hour total fly time. 2,000 Canadian dollars, and your flight path is Pikangikum to Sioux Lookout to Winnipeg, and then to YYZ, and then down the highway to us here in Hamilton. So again, just to emphasize that when we talk about global surgery, we are also looking at in-country disparities in countries like ours, Canada. All right, we're going to leave that there, but I did want to set the stage for when we refer to global surgery moving forward. That is really what we're talking about, surgical care systems. So now we're going to move to drones in different area codes. Now, if we just take a look at Rwanda and Canada specifically, so as I mentioned in the bio, I teach quite regularly at the University of Global Health Equity in Rwanda. And there's a story about how I ended up in OB-GYN, which traces back to Rwanda as well. But nevertheless, if we look at Rwanda and Canada, and again, I have to move this Zoom bar here for the folks in the room, we can see Rwanda is there for scale. I positioned it deliberately over Southern Ontario because that's what most of us are familiar with our country's geography. So for reference, east to west, Rwanda is about 169 kilometers across. So that's driving from McMaster University to either Grand Bend or Oshawa in either direction, okay? So it's not a huge country. It's in fact quite small. And at first you might argue, well, our surgical care systems clearly have nothing in common. We have no shared challenges, no shared successes and so forth. The thing is, while rural Canadian communities and residents have to overcome massive distances and obviously, seasonal weather patterns, avalanches, blocked winter roads, and so forth, rural remote Rwandese patients also have to overcome certain things, specifically mountainous terrain, because although it's a small country, it's very hilly, and the roads have to wind in and out and over and around these mountains, and also some unpaved or dirt roads. So this is a quick, time-lapse video taken from those roads right by the university where I teach. So the last 37 kilometers of the 3.5-hour drive takes about an hour and a half. So it's like half of your trip because of course the roads are in that condition and they're slowly working on paving them. But again, just to emphasize what our patients or other patients or clients might have to overcome in order to reach care. Now, another challenge that can occur, say, in Rwanda or other similar countries in the region is that of blood products. So I don't think I have to tell anybody in the room or on the call that, of course, blood products are life-saving. And this is, across patient stages and ages. And commonly, we're talking about trauma patients, right, from road traffic accidents, most commonly in low and middle income countries, our obstetrical patients, our pediatric patients from severe anemia due to malaria, and then during surgical procedures. Now, in low and middle income countries, 54% of blood is given to children. If you look specifically at sub-Saharan Africa, 70% are given to young children with severe anemia from malaria, followed by our obstetric hemorrhage patients. But of course, then that begs the question, well, how do you ensure that there's blood available to every patient at every rural district hospital in a given country or in a given region? And that's obviously trickier, right, at a systems level, because again, more than 80% of a low and middle income country typically resides rurally. So they're going to be going to these rural facilities. And in order to, stock blood there, we have to think about the very complex supply chain. So blood products typically have a very short lifespan. If you're looking at platelets, we're talking 5 days at certain temperatures. If you're looking at red blood cells, you're looking at 42 days at very low temperatures, therefore requiring refrigeration and so forth. Moreover, it's very difficult to predict how much blood a given hospital is going to need. The amount's going to fluctuate depending on what kind of patient rolls in, if there are traumas that happen in the nearby community. And so even if you were to stock it there, invariably there's going to be expiration and wastage if you don't use it by this particular lifespan. But what if facilities didn't have to stock the blood? What if there could be a centralized hub where you store everything at the set temperatures and you can monitor expiration dates and so forth, and then on demand it can be delivered to whichever facility requires it? So that's precisely what Rwanda did. And so they partnered with Zipline, which is an American company based out of Silicon Valley, along with the Rwanda Ministry of Health, to establish these 2 centralized hubs. So they use a sort of hub and spoke model to situate these drones. And so each hub can do about 500 deliveries per day. There's about 20 drones at each hub, and they each cover, you can see the circles are about 80-kilometer radii to cover the very small country of Rwanda. And of course, this also then overcomes the issue of having to drive the blood up and down and around all of these mountains, which we'll get to. Now, all of the subsequent photos and images were taken from my visit to the Zipline Hub when I was teaching in Rwanda in March, because the master's students that I was working with were doing a field visit in their global surgery projects to look at how the Zipline Hub was functioning and their various challenges and successes. So the entire order, like request delivery process, it's all electronic. And so what will happen is if you're a practitioner at a rural facility, you enter via WhatsApp or their electronic system your request for blood. It immediately beams over to the Zipline Hub, whichever one is closest to you. And then from the time of order request to packing is 5 minutes. Okay, and so now let's assume that there's blood in that red box. We're going to see it get loaded, and then we'll see the drone get docked. Okay, so that's getting loaded, and let's watch it getting docked onto the launcher.
The recovery system. And then this is the recovery system.
And final components getting docked. So that's the battery, and then that's the little like head cap. So the white parts are actually all foam. It's hard to tell from these videos, but they're super lightweight. So when you see one of the up close photos, you'll see it's literally, it looks like our packing foam, the things that come in your boxes to pad your, your new product. So it's very, very lightweight and intentional. Doesn't want me to advance. Okay. So let's watch the exciting part. Want to see it again? It doesn't get old for me. I like watching this. So we missed a part. They do a bunch of safety checks before the actual launch. And in fact, it's all done by QR code. So it's completely modular. And so the technicians will go around scanning QR codes. And if one particular part is off, defective, not safe, they just remove that one part. So then that saves time in having to redock the entire apparatus, again, minimizing that time to delivery. So let's watch the launch one more time, just because it's so much fun. And so just for interest, I think there's someone from iBiomed in the room, so you would like these numbers. So the maximum speed it's reaching is about 97 kilometers per hour, and you can see it's hitting those speeds in a matter of seconds, not even minutes. The average carrying capacity is about 4 pounds. I can send you the link to the big video. I'm sure you're going to be interested in that. All right. And so how do we think, so if you guys have seen this, you're not allowed to answer. Okay, same with the folks online. But if you have never seen this before, how do we think, including the folks online, that the actual blood gets into the hands of the nurse? So now it's launched and it's flying around in the air. It's going to go to the destination by GPS coordinates. But how does it actually get to the nurse? What do we think?
Doors open in the parachute.
Yeah.
Amazon delivery.
Right. And so, I mean, there's a little hint on the slide, but a lot of people initially will say, well, we just have to like figure out landing pads at every single rural district hospital, and then you're going to safely land the drone. Naturally, that's how planes land. But the issue with that is that you then have to build and maintain the infrastructure for a landing pad at every single little rural district hospital. And of course, that's not sustainable over time, and invariably will just result in the technology being abandoned. And so I'll show you a very quick clip here of it landing.
For the ones who build it, fix it, and maintain it, the clock is always ticking. For the ones who need it fast, count on great.
This episode of Real Engineering is brought to you by Brilliant, a problem-solving website that teaches flight.
One second. It would be funny if we had a zip line. All right, here we go.
To avoid having to land at the destination, the plane simply drops the supplies in an insulated cardboard box with a simple parachute, which can then be thrown away, meaning the clinics need no infrastructure to sign up as a client of the distribution center. When the plane does eventually need to land, the procedure to allow it to land with no pilot is even more incredible.
All right, so how do we think it's going to land? So now it's deployed, it's dropped off, the requested blood product. It's now coming back again by GPS coordinates. So they like rehome it back to the hub. we have to fetch it though, right? We're not going to sacrifice each of these drones. So how do we get it back safely? Someone online? Okay, someone's saying parachute, like parachute of the actual drone. Someone's saying a net, so like catch it. Any thoughts online as to how we're going to land this drone? Because this is not sustainable, right? If we
have a landing pad there dedicated.
okay, landing pad. So then over time though, the impact, repeated impact, right? 500 deliveries a day, over 20 drones. That's also going to be problematic.
Okay.
No thoughts online as to how we're going to land this drone?
Once again,
Pardon? This is how,
Okay.
very close. This is how we do it. Okay. So you're right in that there used to be a landing pad. I'll send you guys the link, but the first iteration was that they had this huge, kind of like the mattress pads that like firefighters use. They had a giant one at each of the hubs. But they found, again, over time, it wasn't, sustainable and would affect the durability of the drones. But secondly, Rwanda, it rains a lot. And so they were having to get the technicians to like crawl into this mattress pad each time to fetch the drone out of a puddle of water during rainy season. And so they came up with this particular method. And so it's hard to see here, but there's a little tiny hook at the back end of the drone. And so as the coordinates like bring it closer to the hub, this little string apparatus gets ready to catch the hook. And then you can see it just sort of catches, suspends, and then once it stops swinging, someone will run out and grab it. Questions? Yeah, for sure.
Why did they choose a fixed wing thing as opposed to a helicopter drone that you can land and stuff like that?
Great question. My understanding, so the question here, just in case the folks online can't hear it, is why did they choose a fixed wing? So there are some earlier iterations on the wall of, it may come up in the other photos, on the wall of the hub when we were visiting. They all look like this. They were all fixed wing. They were not the sort of spider type. I'm sure there's another term for this. But my understanding is it was because of the weather patterns in Rwanda, and they felt this was a bit more stable. But again, if someone has other insights into that, correct me if I'm wrong. That was one thing I heard during the visit.
Well, the launch and retrieve system you described, it sounds very similar to that on an aircraft carrier.
Yes, it does. All right, so we're gonna very quickly look at what's inside just to make up for some lost time. So this is the hatch rather, where you saw that red box with the blood getting put in. So these are all the boxes that they have with a bit of padding. These are the batteries that are charging that you saw being put into the nose of the plane, if you will. But they also carry like black box data. So they have flight data for every single flight that all of these drones make. And so they're also capturing like weather data, other things. And then every time it comes in for charging, it's also downloading all of that data to their systems. Now, of course, blood, fresh frozen plasma, platelets, and so forth. But they've also extrapolated to other things. So can you guys read that silver label on the fridge there? It was like the best shot I could get. Brad, what does it say?
It says swine semen incubator 1.
It says swine semen incubator 1. Exactly. So they've actually now extrapolated to veterinary medicine. So here in the second image on the right, that's the swine semen, and they're basically helping the One Health folks to breed a certain type of animal that's more resistant to, various infections. They're looking at vectors and, the spread of that to humans and so forth. So fascinating that they've moved to that, and they've actually since further extrapolated to more like tourism type uses in Rwanda.
Books.
I don't know about the 4-pound capacity, but now you're probably interested in the actual data. Because, it's all well and good and very cool to watch drones getting launched, but does it actually have any impact on patient care? And so this is one of the first studies looking at the effects of primary health commodity delivery. This was actually funded by a CHR grant. So this was done about a year after they launched Zipline in Rwanda. They started in 2016. And then after that, they looked at this sort of 2.5-year segment where they delivered almost 13,000 blood products by drone to about 20 hospitals. Now, 43% of those orders were emergency orders. The remaining were the standing sort of like rare blood type, rare product orders. And so as you can see on the right, the drones were found to be 98 minutes faster, and that was statistically significant compared to road delivery. Now, the one knock and one critique of this particular article is that the road delivery times were done via Google Map estimates. And this is because they actually had wanted to go collect data in person for like on-road delivery times, but they were halted by the pandemic when data collection rolled around. But nevertheless, again, drones are much faster, which makes sense with the terrain and topography of a country like Rwanda. Now, that same study also found that after they started drones in Rwanda, so time point 0 here, the vertical dashed line, they saw a decrease in blood wastage. Specifically, they saw a decrease in 7 blood unit expirations per month, which over 12 months was a reduction of 67%. So that's huge for a healthcare system, in particular, one that may be already quite stretched. So these days, we can see the zip line has reached beyond Rwanda. So it's working in the rest of sub-Saharan Africa, doing similar sort of medical supply delivery, blood products and so forth, but also things like HPV vaccines and COVID vaccines, particularly in Ghana during the height of the COVID pandemic. They've also started working, sorry, we might need to dim the lights a bit in the room for you to see this, in the very outskirt islands of Japan called the Goto Islands, so at the very tip of the Japanese archipelago. And they're also doing medical supply deliveries. And then in the US, they've been doing things like pizza delivery, takeout, groceries, and so forth with a slightly different drone model. Now, for those of us that have worked in rural Canada, we're probably thinking, well, this is amazing technology, brilliant. Why aren't we using this here? We obviously have different issues. Our country's not small, it's very large, but we have folks that certainly experience healthcare inequity given that they reside rurally or remotely. And so one particular First Nation called Stilatin First Nation in northern BC, so you can see they're close to Prince George, was experiencing some challenges in getting prescription medications for their elderly in particular. And so they partnered with UBC for this drone transport initiative. So let's watch a quick video clip of the chief, Mr. Mitchell, one healthcare provider and one patient talking about the effects of this technology for them.
That brought to the community was a sense of pride of being the first, but more importantly, being considered. First Nations communities in general are not very high on the list when it comes to medical technology. So what this does, it brings pride to the community. We're the first. We're kind of first step in the technology to bring this to other communities, and we're proud of that. We're proud of the fact that other communities are going to tap us on the shoulder and ask, how did it go? What's your thoughts? Do you think it's a good fit? And everything that we've seen and heard and done here would welcome them to say, you should do this, because it's a good program, it's a good project, and I think you guys would benefit from it.
The community members, both in Fraser Lake and Stilatin, really volunteered their appreciation and enthusiasm for this work. I think it became obvious that as the months ticked by, people's interest and positivity around the whole project grew, and people came to see healthcare providers like myself and wanted their prescription to be sent on a drone. That was really special, and so people saw themselves as being a co-creator in something new. And I think that, again, that was clear today in the closing ceremony of how the communities felt they were part of the DTI, of the Drone Transport Initiative, and that I think really sets us up well for translating the lessons learned to other communities in the future.
When you have to go get your medication, or you have to get a ride to Prince George or anywhere, you have to have the ride already a week ahead, and then we don't know when we get our appointment, and then we have to rush around, find somebody to give us a ride. And that's been my problem. I can't get anybody to go get my medicine for me. It costs me money to go get gas, and when this happened, the drone, when they started bringing that around, At least I had little money to myself. And now I don't have to worry about getting my medicine. Now it comes to me. And it's really awesome that, you know, this can get out to all different people. So I think it's simply awesome.
All right. And again, I'm happy to send you all these links if you're interested in seeing the full clips. But we can see very clearly, even from that 2-minute segment, that by collaborating between the healthcare providers, having the community leadership, as well as the engineers and the innovators, we have already immense impact on actual lives at Stillatin First Nation. Now, we're probably wondering, well, okay, so this is in Canada. Are drones doing anything else in healthcare systems elsewhere? So in Sweden, in fact, they've looked at using drones to deliver AEDs. So these are the classic defibrillators that we all know about. And specifically, this is targeting our out-of-hospital cardiac arrest, right? And as we all know from various like public health messaging and our training, time is muscle, right? Time is cardiac muscle. And so you want to reduce that interval to that person getting care. And so this particular study showed that by delivering drones by AED compared to delivering by EMS or ambulance, they save 16 minutes in time. Now, here in Southern Ontario, we obviously do not have huge distances to travel to get from, you know, home or public place to healthcare system. But of course, we're contending with this notorious traffic congestion, which increases our travel times immensely on the 400 series highways. And so there was actually a drone pilot in Halton Healthcare back in 2019. So this was called Canary or Care by Air. And as you can see, they partnered with Air Canada Cargo. And so they were essentially ferrying lab samples, urine and blood, between Milton District Hospital and Oakville Trafalgar Memorial Hospital. So it's about 13 kilometers between the two. And essentially the pitch was that this would help to accelerate processing, reduce delays in getting results and so forth for patients. Interestingly, there has not been any news about this since they launched. None of the healthcare providers I've asked at Milton District Hospital or Oakville know about this particular initiative when it was happening at the time, nor do they know what's happened since. So I can only surmise that it has not carried on. But again, this is one of those interesting things where I think most of the people in the room here who also work in the region have never heard of drones being used, right, in Southern Ontario. Yeah, and those are my thoughts exactly. Now, drones, of course, are not a medical device, so none of these companies had to go and seek like FDA or equivalent health authority approval. But as with any implementation or intervention, there's going to naturally be challenges. So we've seen that there are lots of extrapolations for it, and some of them are quite contextually relevant and very locally led. But one of the issues that came up in Rwanda was that they needed data for the specific altitude at which these drones were going to be flying in. So they had weather data from like Rwanda Civil Aviation for like 30,000 feet in the air for commercial aircraft, but they didn't know what the weather patterns were going to be like at hundreds of feet above ground, which is where the drones fly. And that's intentional, right? Because you don't want the drones meeting the commercial aircraft. And so in order to get that data, they actually had to hire a meteorologist to then capture all of these different weather patterns. You're navigating hills and mountains, buildings, and so forth. And then getting these weather patterns, putting it up onto their system, and then creating this sort of monitoring platform for them to be able to tell, is it safe? Do I need to avoid this particular area today? Do I have to take a different flight path? This particular map, all of the striped areas are showing you basically no fly zones. So they're not allowed to fly over lakes. They're obviously not allowed to fly over military bases. So again, collecting all that data when they were trying to, pun intended, launch this particular technology. Now, other things, they obviously had to address certain regulations. They had to create different sort of, pieces of legislation or regulation, get government buy-in, but then also train up a completely new cadre of staff to man all of these things or to look after them. So here on the right, you can see, like, this is an image taken from their sort of like central monitoring room. So they have all these like how to reach an engineer for support on Slack. They have this particular flight deck where they're looking at tracking every single drone, every single flight inbound and outbound, all in real time in the event that there are any issues. Now, one of the other challenges I should mention here, I'm kind of mirroring what we heard about happening in Milton and Oakville, is that this doesn't always work. So again, it's very hard to find data on this, but Zipline actually tried to launch in Tanzania in 2017. And so you're going to see lots of articles online about, you know, the hoopla before the launch. Everyone was very excited, and they were working in about 10 regions in the country at that time. Blood, vaccines, all the usual medical supplies. But now it's no longer functioning. And when I talk to my Tanzanian medical colleagues, they tell me that it was an issue of government buy-in and having the appropriate champions at the local level to have it move forward. So again, just to remind us that although there are many successes, there are also ultimately challenges in implementing these technologies. All right, so we're gonna leave drones there, but hopefully I've convinced you using that example that both figuratively and literally, in order to get the idea off the ground, this could not have been done with just one profession, right? We really needed a multitude of professions working together, certainly healthcare providers to demonstrate the need, the engineers and innovators to create the technology, launch it, iterate, create additional prototypes. We needed the policy folks and the government officials to buy in, and obviously also the community health workers, which we haven't touched on, to get community buy-in for the drones. Now we're going to switch gears to another example of interdisciplinary collaboration, and that is Stitch, which again, those of you in the room can see it's on the table here. And so the challenge in this setting is postpartum hemorrhage. So many of you may know postpartum hemorrhage is the leading cause of maternal deaths worldwide. Every year, 14 million people experience PPH and 70,000 people die. So essentially that's one death every 8 minutes, or by the time we're done our talk this morning, 8 people will have died worldwide from this. Now, again, this is not an issue that's isolated only to low and middle income countries. This particular study that was done by colleagues showed that in Ontario in the last 20 years, 27.2% of deaths were due to hemorrhage. Now, the challenge here, of course, is that some of the last ditch efforts are surgical. So there are essentially 3 surgeries that we would do, 2 of which are fertility preserving. The last one, we'd have to take out the uterus, which are an attempt to save that person's life. The issue is that there's not actually a lot of simulators to practice on. And in fact, if you look at the characteristics of the simulators, there's not a truly accessible simulator. So we have on the unrealistic but very affordable end, we have homemade and animal options, which have questionable anatomic accuracy. And then on the very realistic end, including, you know, you get your fake blood and everything, they come at an astronomical price tag of 10 to 55,000 USD, which I will say that I see Dr. Chamberlain's here in the room, and you know, some of my other OB-GYN colleagues in the room. I'd argue that our department for sure, our institution even across departments, would not have the budget for a simulator like that. And then if you're thinking about training up multiple rounds of residents or staff, that would be unattainable for us. So that was a large gap that I had identified both in my own experience as a resident, but also in my teaching. Another gap, if you will, is in training overall. And I don't think I need to really convince this crowd. I think I'm preaching to the choir, but in case there are any doubters as to the exponential impact of teaching and why we need to invest in surgical education, this is a February 2024 study, actually from plastic surgery, that was one of the first to actually quantify the impact of a single surgeon's training. And so as you can see from this infographic, they found that training a single surgeon in a low-income country can have a lifetime impact of over 400,000 patients through their training alone. And so these are not all direct patients that they're treating themselves, but as they're treating and doing their clinical work, they're also training up the first generation of providers. They then go to train the second generation, and then you ultimately have this multi-generational multiplier effect. And so again, just to emphasize the impact of training, no matter where you are in the world. And then one other gap that I noticed was that we actually don't have a lot of data as to how we feel about these 3 surgeries. So I couldn't find any data from anywhere else in the world, Canada, US, the rest of Europe, Asia, Sub-Saharan Africa. The only study that exists is that of French OBs and OB-GYN residents. And so you can see from the 2016 and 2019 studies, about a third of OB-GYNs felt that they themselves had not mastered the three main surgeries. So you can ignore the internal iliac artery ligation. I would argue that's a little bit more advanced, but certainly the first one, second one, and the fourth one are the particular surgeries that we're looking at. And about a third we're not comfortable. And then when we look at the OB-GYN residents, so these are fourth and fifth year, so it's they're very senior residents. And in France, you're actually allowed to practice independently at fourth and fifth year, which is different from our system. But nevertheless, again, first, second, and fourth procedures, there is 75 to 85% of these residents felt that they had not mastered these surgeries. So that was yet again, more evidence of this gap. And so to fill this gap, I started imagining this modular, reusable, portable simulator that we could create for folks all over the world. And in OB specifically, I think similar to our orthopedics colleagues in general surgery, elsewhere in the world, it's very much a task-shifted specialty in that it's not just specialist surgeons that are doing some of these procedures, but also generalists, GPs, family physician equivalents. And so this is actually a very seldom seen page out of my notebook from 4 years ago when I started dreaming up this simulator. So you can see my, very futile attempts at trying to draw out the anatomy. But at that time, I also realized that, this is one of those scenarios where I, as a clinician alone, although I recognize the gaps in healthcare and in surgical education at this point, I could not make this simulator on my own. I did not have the ability to create, to know what types of materials to use, to iterate prototypes. And so I knew that I had to find myself some engineering friends. And so these are my engineering friends. So this is the Stitch team. So there are 5 biomedical engineers who each bring a complementary area of specialty to the team. So in the same way that we have our own specialties in medicine, they also have their own specialties. And together we created Stitch. So it does, as Dr. Levis said, come as an educational bundle with 3 surgical tutorial videos. I'll show you one here just to run in the background that allows users to review the surgeries on demand. In particular, thinking about folks around the world who may not have specialist faculty around them all the time, this helps to equitize that access. And so right now you're watching a B-Lynch compression suture. So that's basically putting a belt and suspenders on the uterus to then externally squeeze the uterus to stop it from hemorrhaging and hopefully save the person's life. So that's often the first or the second of the 3 procedures that we would do. And so what you're seeing here, the base is crafted off of a female MRI pelvis. So the OB-GYN and general surgeons that have tried it tell me it really feels like that tight, narrow breadth and depth of operating the pelvis. And that's the reason why, because it's based off of somebody's MRI. The base, the skin, the ureters that are inside are all reusable indefinitely. And then the uterus that you see and all of the attached organs, ligaments, and blood vessels can be used about 50 times for the first 2 of the 3 procedures. And then you would do a hysterectomy and then reset the model with a new uterus. Now we have some validation data from clinical end users, these 54, that show that more than 90% rated Stitch as good or excellent here in the bright blue horizontal bars in terms of educational value for the 3 surgeries, the fidelity in terms of anatomic accuracy and the feel, as well as the ease of use. So we're quite excited about that. Now, again, I've said this already, but Stitch really would not exist without this interdisciplinary collaboration. So combining medicine or surgery with engineering. But really the first challenge is how do you find each other? Because engineers and clinicians don't often encounter each other. We don't hang around the same spaces, even at the university level, right? We usually have different buildings, different, grounds, different talks, different lectures. And so in order to cross paths, there are actually programs like this. So I met this particular team through Engineers and Scrubs because I hold an adjunct appointment at UBC where I teach one of the master's courses in global surgery. But here at McMaster, we do have very similar programs. So there used to be, I think, you can correct me if I'm wrong, an Innovators and Scrubs program. I'm not sure if that's still running, but that's for 3rd and 4th year undergrad engineering students. And then there's the 5th year capstone project as well, where they do seek clinician partners to bring some sort of like healthcare gap or problem to solve. And then finally, there's the Masters of Biomedical Innovation that was recently started through the HearSyncs, which again is attempting to bring together clinicians with innovators to solve either local or global healthcare issues. The second challenge that we realized in working together as an interdisciplinary team is that we approach things very differently. And this traces back to how we're trained. So this is all taken from what the engineers tell me, but they say, you know, we like numbers. We love numbers. We like quantitative things. We want you to tell us numbers, like criteria that are measurable, calculations. That's what we want from you. Whereas in surgery, I mean, we just know, right? Like if the tissue feels like correct or incorrect, for lack of a better way of putting it, in our OB sphere, we're talking a boggy, atonic, non-contracted uterus versus contracted. We don't have numbers for you. We just know when we feel. And so it came to the point where, say, you know, we're trying to create prototypes for stitch. And I know to the surgeons in the room, you're like, well, duh, that's what a uterus looks like. Of course, it should look like this. But it actually took thousands of decisions to get it to arrive to this point. And in making those decisions, in choosing the materials and so forth, they were asking me things like, I need the density, tensile strength, shear modulus, and viscoelastic response of the uterus, or the ligament, or the ureter. And I was like, let me feel something. Like, I don't know. I don't have a number for you. And so that's literally what we did when it came time to pick materials, right? So we had like a feel session. So it was just like a whole buffet of materials, and some of my colleagues from UBC helped us out with this part as well. And so it was just down to feel, like this resembles, or this plus this resembles what I think, you know, an atonic postpartum uterus would feel like, and so forth. So again, just to emphasize to you, there are some challenges that are, you know, navigatable, but that were unanticipated. And then finally, you know, again, as surgeons, we're taught to quite quickly come to a diagnosis, right? You need a differential in order to start implementing your management plan. Engineers, I'm told, are taught to keep solutions rather broad at the outset. You don't want to narrow down too quickly. That's not good for the engineering or prototyping process. You need to stay broad and, you know, keep your options open. So again, that was something we navigated early on in prototyping for Stitch. And so looking towards the future, just being mindful of time, we're very excited to be partnering or have partnered with some of these organizations. So right now we have validation studies being run on the rural physicians here in Canada, as well as with a group of Tanzanian rural GPs and OB-GYNs. There should be a stitch actually being used today by the OB-GYN residents, if I'm not mistaken, here at McMaster. And then we're very excited to be co-hosting a workshop at the big biennial World Congress for the International Federation of OB-GYNs, which will help us to hopefully reach more people across other regions of the world. And so I'd be remiss to end this talk without doing a, you know, shameless plug for our graduate diploma in global surgery, some of the faculty which are in the room here. So again, going back to the original definitions I gave you of global surgery, if anyone's interested in learning more, this is a new offering that we have at McMaster that really is for anyone with a bachelor's. So again, back to my comment about, you know, global surgery is not just for healthcare providers. Similarly, this diploma is not just for healthcare providers. So it is for anyone with a bachelor's who wants to learn more about the field of global surgery and how that might complement their existing skill set. So it is for graduate courses that are completely online and asynchronous in order to allow for maximal flexibility. So it can be taken from anywhere in the world, which then will help to overcome time zone, financial, visa barriers, but also, of course, you know, life stage, career stage barriers. And our faculty is interdisciplinary and from both high income countries and low and middle income countries. Those of us in the top row are the core faculty. So Mr. David Oldenberger is here in the room. Dr. Brad Petrosor and Dr. Carolyn Levis are also here in the room. And then we have a couple of colleagues, one from University of Global Health Equity in Rwanda, Dr. Pierrette, who's a GP by training and now in academic global surgery, and Dr. Godfrey Sama Filippo from Tanzania, who's also GP by training, but works as a research coordinator for COSEXA. We have a couple more faculty, guest faculty pending in discussions, but these were the ones that I wanted to let you know about at this time. And just to give you a quick overview, this is where our faculty has worked, primarily clinically, but also in other capacities. So you can see this ranges from rural remote Canada to the Caribbean and Latin America, to sub-Saharan Africa, to Asia and Europe. So bringing a wealth of experience to our diploma. And so to conclude, hopefully I've convinced you that global surgery is about surgical care systems and that well-functioning systems require interdisciplinary collaboration. Unfortunately, there is no perfect healthcare system in the world, and there will always be gaps. And so again, hopefully I've inspired you to pursue these innovative, impactful, scalable solutions through interdisciplinary collaboration to address these gaps. So thank you so much. I will pause there and happy to take any questions.